Sure, we can. Do you guys want to start or you want to take a little bit of time?
Yes, I'll start. Good morning, everyone. Welcome to TeleShadowing. We're live on YouTube. Please feel free to ask any questions in the chat box as we go along, and they'll be addressed. And now I'll pass it on to Rufai to introduce our mentor for today.
I am honored to introduce our mentor for today, Dr. Barbara Rana. Dr. Barbara Rana is a general adult psychiatrist with Vancouver Coastal Health Service and Burnaby Psychiatric Services. She has been the CME coordinator for Burnaby Psychiatric Services for the past 20 years and plays a pivotal role in the development of several important educational initiatives. Dr. Rana brings a culturally sensitive lens to her clinical practice and provides mentorship to her colleagues around the multicultural issues. She volunteers her time for public awareness initiatives and destigmatize mental health issues. For the past 3 years, she has been doing monthly radio shows to raise awareness and create dialogue about mental health. She has been nominated for the British Columbia Multicultural Award for her various accomplishments. Dr. Rana is the founder of the Pakistani Canadian Women's Society, or PCWS, and works tirelessly to promote the empowerment of women. The PCWS conducts regular educational events and provides skill-based workshops for South Asian women trying to enter the workforce. Dr. Rana is the director on the Pakistan Festival Organizing Committee. She is also a board member of the Vancouver International South Asian Film Festival. She was awarded Woman of the Decade in the Community Leadership and Social Innovation by the All Lady League and Women Economic Forum. She has been nominated by the Women Economic Forum to be a director. Dr. Rana is the member of the Association of Pakistan's Physicians of North America, or APPNA, and is an international speaker for them. She has received multiple awards for community work and has been awarded a medal from Senate of Canada for community work. It is currently 7 a.m. in Vancouver, and it really shows Dr. Rana's dedication to mentor students. And now it's my honor to request Dr. Rana to begin today's session. Thank you.
Thank you for such a long introduction. I wasn't expecting it. Anyway, so I'm just going to go over management of mood disorders with you guys. I don't know, like the audience, whether these are medical students or other students, but anyway, if there is something too complicated or you guys want me to make it simple for you guys, just please let me know, okay? Next slide. Can I do the slides myself from here?
Usually it doesn't work for physicians to do that, but if you just tell us to go next, we can make sure it happens.
We can do that. Okay, next. So basically what I'm going to do is, the objectives are that I'm going to go over how to evaluate the mood disorders. If somebody has depression, mania, hypomania, or any kind of mood disorders, then I'm going to look at the classification, like how does the DSM-5 classify the mood disorders, and then we will go over how do we manage it. Next. So first of all, how do you define mood? What is mood actually? Mood is actually defined as a pervasive and sustained feeling that is endure internally, but what it does is it impacts actually nearly all aspects of person's behavior in the external world. Now, if you look at DSM-5, DSM-5 used to have just one category of, DSM-4 had just one category of mood disorders, but now they have divided into two categories in DSM-5. One is bipolar and related disorder, and the other one is depressive disorders. Next slide. Next slide. Mood disorders are actually very common. Maybe depression is more common than bipolar affective disorder, but mood disorders are actually quite common. So if you look at bipolar disorder, bipolar 1 disorder, it's around 0.5 to 2.4%. Type 2 is around 0.2 to 5%. And if you look at the whole spectrum, it's around 3 to 6.5%. And bipolar disorder is actually equally common, both men and women. Next slide. The importance of mood disorder is that that they have the suicidal behavior is one of the symptoms of depression and mania and hypomania both. So the suicide risk is actually very high. It's around 17 to 19% is the suicide risk. I'm just talking about bipolar disorder right now. And age of onset is usually very young, that is between 17 to 21 years. And that's a time when people are going to the university or starting their relationships, and their whole life is disrupted because of the illness. Next slide. Now we are talking about major depressive disorder. If you look at the lifetime prevalence, it's very high. It's around 5 to 17%. In women, it's around, you can say around 17%, in men around 12%. It's twice as common in women as compared to men. Median age of onset is around 32 years. And I won't go over the Canada one. So next slide. And it costs a lot of money to the system. So I'll just look at the USA one. If you see that lifetime cost of bipolar affective disorder in USA in 1998 was around 24 billion. That's how much it cost. And again, the global burden is huge for major depressive disorder and bipolar disorder. Next slide. First, before we talk about like how do you kind of classify the mood disorder, I'm just going to go over the symptoms of depression and mania, hypomania, both, to make it simple for you guys. So what we use especially when I do my assessments, I still use these acronyms to kind of like go over the information with my patients. So for depression, it is SIGI-CAP. So S is for sleep, and I'm not going to look at each of them, but I'll go over the symptoms. So people who have depression, their sleep is impaired. So either they will sleep too much or they don't sleep at all. They have insomnia, where they have difficulty falling asleep, staying asleep, and sometimes they will be up at 4 o'clock in the morning and then they cannot go back to sleep. They have lack of interest. They are not interested in anything they did before, their hobbies and rest of the stuff. Socially withdrawn, do not want to interact with people. Preoccupation with guilt feelings. They blame themselves for everything. Their self-esteem gets affected. Self-esteem is really low. Thinking becomes very, very negative. Energy level is very low. And if they have anxiety with it, then they will be very agitated. Concentration is poor and memory is poor. So sometimes, like especially in the elderly people, the concentration and memory is so poor that it is like pseudo dementia. So it feels like that the elderly person is suffering from dementia, but actually it is depression. Their appetite is affected. So sometimes they won't eat at all. There's loss of appetite. At other times, they eat too much, and they will be eating sweets, carbohydrates, and that kind of stuff, and gain weight. Lack of pleasure. Anything they do, there is no pleasure in anything they do. And most important one is suicidal risk. A lot of people who have depression, especially the severe depression, they have suicidal thinking. They will be thinking of killing themselves or hurting themselves. So that is the most important symptom that you have to look for. Next slide. Now, when they are manic or hypomanic, then it is the opposite. So what I use for it is grasp it. So they have grandiosity, which means their mood is elevated, obviously, and very, very grandiose. For example, they will feel that they're God, or they are a messenger sent by the God, or they will feel, one of my Chinese patients, he thought that he created the world. Actually, he created the flowers. So very, very grandiose thinking. Thoughts are racing in their mind, very, very fast thoughts. So basically, they are not able to do anything because of the racing of thoughts. They plan excessively. They will be going, okay, I'm going to do this, I'm going to do that, but they are unable to actually achieve anything because of the lack of concentration and jumping from one thing to another stuff. Hyperactive, extremely hyper, cannot sit still, walking, pacing, agitated. Sleep is poor. They don't sleep at night, but in the morning, they don't feel tired. Still, their energy level is high. Excessively involved in pleasurable activities like drinking and becoming promiscuous, getting involved with stuff which could be harmful to them, which is impulsiveness, spending money inappropriately, very, very talkative. It is difficult to actually interrupt these people. And when they're very manic, at that time, their speech gets totally like disorganized. You can't make anything out of it. They are talking so much and so fast. And some of the time, like I've seen patients like where when it is very, very severe, then they become psychotic. They start hearing things, they start seeing things, and behavior becomes extremely inappropriate, like standing naked in the middle of a road. So in those cases, they need hospitalization. Next slide. Next slide. Now, I'm just briefly going to look at the classification of DSM-5. How does it classifies? I think we need to go to the slide before that. That is on bipolar. Is this the next slide? After this, which one? Okay. Anyway, so let's look at a major depressive disorder first. Can you go back? Yeah. So I'm not going to again go over all the how the DSM-5 classifies these mood disorders because it's a very lengthy topic. Anyway, the most important ones are major depressive disorder. Major depressive disorder is that your mood has to be depressed at least for 2 weeks. And then there are 2 symptoms which has to be present. One is either depressed mood or lack of interest. And then out of the other symptoms I talked about, you have to have 5 symptoms in total to diagnose. Persistent depressive disorder is more like the milder symptoms, but it lasts for a long time. Like people with persistent depressive disorder will come and say to you, they have been depressed for all their life, but it is a milder form of depression or symptom-wise. Then premenstrual dysphoric disorder is more like people who get like depressed a week or before the menstruation, and they have all the symptoms. And they have a new one, which is a disruptive mood dysregulation disorder, where they have anger outburst and their mood is totally unstable, but more like depressed. They also have the categories where depression is induced by either medications or by a medical condition. Next slide. Then you have bipolar affective disorder. As I said before, it is common, it is recurrent, and it is highly debilitating condition. And it is divided into bipolar 1 disorder. In bipolar 1 disorder, you have at least one manic episode. You cannot diagnose bipolar disorder without a manic episode. Although most of the patients who have a bipolar disorder, they spend more time in having depression rather than mania or hypomania. So manic episode has to last at least for a week or 5 days to a week. And then the symptoms, I have already talked to you about that. They have to have 4 to 5 symptoms. Bipolar 2 is a milder form of disorder because it doesn't affect the functioning the way bipolar 1 disorder does. So all these psychiatric conditions, other conditions to diagnose them is that they have to affect your functioning, that you're unable to function because of the illness. Cyclothymia is more for around 2 years. You have mood fluctuation where you go up and down, but again, like the depressive episodes and high episodes are a little bit milder. Then again, further classification is that bipolar disorder induced by medications, bipolar disorder induced by substance use. Next slide. Next slide. Now, when you are seeing somebody with a mood disorder, especially the family physicians, how would you screen someone that they have a bipolar disorder? So I will, even if you ask 2 questions from a person, like, is there any change in your mood, or is there any change in your interest level? That would give you some clue. And after that, then you can do the further like extensive assessment of that patient. And sometimes what happens is that, especially in our culture, like in Asian cultures, people don't present with depressed mood, or they won't say that they are depressed, because in our in Asian cultures, emotions are not expressed. So they will come with somatic complaints, like they will go, oh, my body is hurting, I'm having a headache, I have a gas in my stomach, which is very common in Indian and Pakistanis. So they will come with those kind of symptoms. So if you are like, you will see that a lot of people who will come with somatic symptoms, once like you have ruled out all the medical conditions, then you should think about that maybe this person is depressed or they're anxious. That's why they are presenting with these kind of symptoms. Next slide. Now, how would you interview a person to diagnose a mood disorder? First of all, when they come, you should need that is a principle in psychiatry, that you don't ask the open-ended questions. You let them talk first. Let them present their own symptoms, like why are they there? Why do they want to see a psychiatrist? And then ask the open-ended questions yourself. And once you have a little bit of sense, then ask the direct questions about their symptoms, right? Whether it is depression or mania. Then you need to know, like, how long have they been feeling depressed or manic? Did they have any episodes before? And when they had the episodes, how long did they last? And did they cause any problems for them, whether it is depression or mania or hypomania? Did it affect their relationships? Did it affect their ability to work? Did it affect their social circle or relationship with wife or husband or children? A lot of time with bipolar disorder, it really affects your functioning or relationship with other people because of your inappropriate behavior. And a lot of time people who are manic or hypomanic, they also become very irritable, angry, and have an anger outburst. Most important symptom you have to ask about is suicidal ideations. For suicidal ideations, you need to know whether like they're chronic, they're present all the time, or are they acute? And does the person plans to hurt themselves? So you need to ask this direct question, like, do you have any intent of hurting yourself? A lot of time people think that if you ask somebody about the suicidal thoughts, you may aggravate it, but that's not true. Actually, it is a relief for the patient when you ask them. Ask them about the plan. Do they have any plan? Do they have any weapons available? How are they going to do it? If they are saying, I'm going to overdose, do they have the medications available? Some people, when they're before committing the suicide, they will write a letter to the family. And when this kind of stuff happens, that they are giving away their property or their things or writing letters, most likely it is very serious. And sometimes, as I said before, even in depression or mania or hypomania, not in hypomania, people can develop psychotic symptoms and lose touch with the reality, where they hear things, they see things, they feel paranoid that people are out to get them. They will feel that some outer force is controlling them, or people are talking about them, TV is talking about them, so they get psychotic. And then consider like doing a mood disorder questionnaire. I don't do that personally, but I think it is good for family physicians. Then very, very important to ask two more questions, which is family history, because most of the psychiatric disorders, they run in the families. There is a genetic predisposition. And also it is helpful that if somebody, for example, has bipolar disorder, and they use certain medications, it worked for the family members, most likely it will work for them too. So it's very important to get the history about the family. And again, especially in mania and hypomania, very, very important to get the information from the family. A lot of time, because especially in hypomanic state, the patient is quite elevated, happy, doing their own stuff, functioning not that badly. So they don't feel that there is anything wrong with them or they are having a manic or hypomanic episode. So it is very important to get the collateral information from the family members and clarify. I always, with my bipolar patients, I always get the collateral information from a friend or a family member, whoever knows the person best. Next slide, sorry. When you are doing the assessment, also consider that these symptoms are not caused by a medical condition, because there are a lot of medical conditions which can lead to depression and mania. Again, substance use. 50% of the cases that I see in emerge, they are from substance use or induced by stimulants or cocaine or marijuana. So very important to rule out that there is no substance use there. And also consider the medical conditions, medications, that can lead to symptoms of depression or mania or hypomania. For example, beta blockers can cause depression. Next slide. There are a lot of screening tools you can use. PHQ-9 is the one which is used most commonly by the family physicians. Hamilton Depression Rating Scale, again, is used quite commonly. Bipolar Spectrum Diagnosis Scale. So there are different scales. I'm not going to go over them. Next slide. Now, what are the risk factors for suicidal behaviors? When you're assessing a patient, you have to see whether they have any of these risk behaviors. For bipolar disorder, there is history of suicidal attempts. If there are, this is very important actually. If they have done the previous attempts, that makes them more vulnerable to future one. If they are using alcohol or substances, a lot of time people, they are drunk, they are impulsive, and they don't realize the consequence of their own behavior. So they will take overdoses or will do something to themselves. Level of pessimism is like feeling of hopelessness, like not seeing anything in the future or feeling hopeless about their situation. That is also a risk factor. If they are very, very aggressive and impulsive, a younger age of onset, if somebody becomes sick at a very young age and don't see any future for themselves. And again, family history of suicidal behavior. In depression, older men at high risk, if you're a sexual minority, there is a high risk. Stressful life events, for example, somebody very close to you died. In older people especially, when one spouse dies, other one is at a high risk. Post-traumatic stress disorder is a high risk. Personality disorders like borderline personality, people have tendency to attempt suicide and hurt themselves. And then if they had a lot of severe episodes of depression and not getting better, that is another risk factor. Next slide. So how do you treat patients with mood disorders? Next slide. First of all, what are the goals of the treatment? First goal is that you have to treat their symptoms. When they come with depression or mania, you have to make sure that they are controlled, like the symptoms of depression and mania are controlled. Second aim is that they return to their psychosocial functioning, like they start working again, their relationships get normalized, and they have normal life. Third goal is that they don't have another episode again, and they don't have recurrence or relapses. Because with depression and mania, both with bipolar and depression, more episodes you have, more brain damage you have, it becomes severe, you end up being on more medications. So it is and also it affects, like, your functioning goes down with each episode. So it is very, very important that you prevent the relapse and recurrence. Next slide. I hope it is not too complicated. Are there any questions up till now?
Not yet, but we'll compile them and we'll ask them towards the end during the Q&A session.
Okay. So when you start treating somebody with depression or any mood disorders, first of all, you will do the diagnostic evaluation, which we talked about. And second important thing is that you have to assess the safety and level of functioning. What I mean by that is that if somebody is coming with suicidal ideations and you feel that this person is not safe, right? You cannot send them home, then you need to consider hospitalization. Level of functioning, for example, somebody comes with mania and they are totally disorganized in their behavior. A lot of time, the police actually brings the people who are manic to the emergency department because of their inappropriate behavior. Like they will be very, very aggressive, or as I said before, like sometimes they are naked and they are doing stuff which is totally inappropriate. So because of that, you need to consider like how their functioning is in depression. If they are not eating, if they are not taking care of themselves, there are no social supports. So you need to consider then hospitalization. So second thing is that you assess the safety and level of functioning of these patients before you start treatment. So once you have done that, then you make a plan, like what am I going to do with this patient and what will be the optimum treatment. So once you have decided that, then the secondary objective will be that you develop a therapeutic alliance with that person or relationship with that person. And as you treat them, you monitor their mental state, whether they are responding to the medications or not, and educate them about their illness, because all these illnesses are chronic. They need long-term treatment. If you educate them, then they will be more compliant to the treatment and try to minimize the functional impairment. Next slide. Now, when you are, as I said, when you start the treatment, the first thing you need to do, those were the objectives. But before you start the treatment, other things you need to do is to rule out they don't have a medical condition which is causing the depression or mania or hypomania. There are multiple medical disorders which can lead to the mania or hypomania or depression. I'm not going to go over all of them. I just can give one example that one of my patients, she had depression and I was treating her for a long time and she wasn't getting better. So my assumption is that the family physician has done all the blood tests. So I didn't do the blood test on her. But anyway, then I ended up doing the TSH and she was hypothyroid. Once the hypothyroidism was treated, and then her depression became better, right? So it is very, very important that you rule out that they don't have any medical condition which is leading to a mood disorder. Next slide. As I said before, also, a lot of drugs, for example, cocaine. Cocaine can cause actually initial elevation in mood, and then it leads to depression. And it can also lead to psychosis, actually. So stimulants most likely leads to behavior, which is very hyper, and it appears like they almost look like manic or hypomanic patients. So again, you need to rule out that they are not intoxicated or going through the drug withdrawal, which is leading to the symptoms. Because most of the patients who are admitted in Emerge because of stimulant-induced behavior changes or whatever, they can be discharged next day or in next 1 or 2 days. Next slide. So when you are assessing somebody for secondary mood disorders, which is caused by like medical condition or substance use, you need to do a detailed history. You need to do their general physical examination, and you need to order the appropriate blood tests. We do the urine for drug analysis on every patient who is in Emerge, actually. So I have the panel here. So you need to do all these blood tests to rule out that they don't have a medical condition which is causing them the symptoms. Next slide. So when you start somebody on medications, what would be the principles of starting the pharmacotherapy? So we talked about this already, that you do a detailed clinical assessment where you have to look at whether they are suicidal or not. Do they have history of bipolarity? Are there any medical conditions or other conditions which can be causing it? Are there any medications they are taking which is leading to it? Or and then you talk to the patient and talk about evidence-based treatment, whether it is pharmacological or non-pharmacological treatment, and give the patient an option to decide what do they want. That will improve their compliance and also relationship with the patient. So if somebody comes to me and they are having their first episode of depression, and it is not like they are not suicidal or they are not going to hurt anybody else, I usually ask them. I just saw on the weekend a patient who told me that she does not want to take the medications and she would like to have psychotherapy. So I said, okay, fine. So let's do the behavioral intervention and psychotherapy first. And if it doesn't work, will you consider medications then? She said, yeah, then she will consider the medications. And we said, okay, fine. But obviously, if somebody is suicidal or they're homicidal, that they are going to hurt somebody else or hurt themselves, then they need to be hospitalized. And then you don't ask them about the treatment. They're usually admitted as involuntary patients. And then before you start somebody on medication, especially if somebody has chronic history, you need to evaluate whether they have used any other medications before. And if they use the medication, how long did they use it? Were they effective? Were there any side effects? So go over most of that information. And then depending on their condition or whatever, look at whether you need to order any blood tests. I usually personally, if I see somebody the first time, I like to do the basic blood work. Especially like a lot of medications, they lead to hyperlipidemia, like the people get obese or their lipid level goes up. Or so I will do the fasting blood sugar or hemoglobin A1C. I'll check their lipid before I start them on medications and monitor them once a year. Thyroid, TSH is important to do. So some of the blood test needs to be done. And once you have started them on medications, and at least for the first time, you should at least see them within 2 weeks to see whether they are responding or they are having any side effects. And then every 2 to 4 weeks, you should assess the patient. Next slide. If somebody, so those were the general principle I talked about, starting somebody on medications. But if somebody is coming with mania or their behavior is very dangerous or they have psychotic features, then you have to obviously assess these things and act accordingly. You cannot treat them as outpatient. They have to be admitted to the hospital. Next slide. Again, I'm not going to talk in detail about the medications, but basically patients who come with mania and psychosis, they need to be treated with a combination of mood stabilizers and antipsychotic medications. So initially when they come, we usually start them on a mood stabilizers. Most of the antipsychotic medications are also actually mood stabilizers. So we use a combination. So there are a lot of medications now available which we can use. And patients who have milder symptoms and they are not admitted, they need to be reassessed every few days, 2 to 5 days or whatever, to see whether there is any improvement or not. Next slide. There are a lot of studies on the combination of various medications which are effective. Again, I won't go over them. Next slide. If somebody, again, somebody has bipolar depression, as I said before, that a lot of people with bipolar illness, they spend most of their time in depressed state rather than manic or hypomanic state. and there is high risk of suicide with that. So if they come with suicidal ideations, again, you need to look at hospitalization. And in these patients, ECT is also a treatment that you can look at. Next slide. These are the medications we use basically for acute mania. I don't know whether you guys want to know about that or not. Again, I don't know like the kind of audience I have right now. What would you say? Do you want me to go over the medications?
Yeah, that'd be fine. We have some med students and undergrads, so you can go over if you like.
Okay. So if we look at the medications we used in acute mania, there are mood stabilizers such as lithium and Epival. And then there are, as I said before, most of the antipsychotic medications like risperidone, Seroquel, asanapine, they are all effective for the treatment of acute mania. Lithium is one of the medications which is used as a first line because it's very effective, and also there is a lot of it has been used for a long time, and we know there's a lot of clinical information on that. So because of that, lithium is a first line treatment. Next slide. Okay, so there is a like I have gone over this stuff with you guys already. So next slide. How do you treat bipolar depression? That is the most difficult thing actually to do. We have good treatment for if somebody has a major depressive episode, or if we have a mania or like manic or hypomanic episodes. But bipolar depression, we don't have as much data on that or studies on that. And it is actually very, like most of the time, it is quite like affect the functioning of the person. And as I said, there's a high suicide risk too, so it needs to be treated. But we don't have a lot of data for the treatment. There are few studies. One is on olanzapine and fluoxetine combination, which is FDA indicated treatment. Seroquel is another one, which is quite effective, and there's a lot of data on it. Lamotrigine, mostly positive data on it. And antidepressants, there is weak data on that one. So, and now lurasidone is another medication which has been studied, and it is found to be effective. That's more recent stuff. Next slide. So this is a study on the combination of fluoxetine and olanzapine. And you can see that the purple one is olanzapine, black is just placebo, and pink is the combination of olanzapine and fluoxetine. And you can see that combination of olanzapine and fluoxetine is much more effective as compared to the combination. Next slide. So the response rate or remission rate in the olanzapine group was around 32%. Placebo group was 24%, and for the combination was around 50%. So there is quite a bit of difference actually. Next slide. Seroquel monotherapy, which I use myself a lot, that people who have depression because of the bipolar illness, because Seroquel does a lot of things, helps you to sleep. It also stabilizes your mood, treats the depression. It is an antipsychotic medication, so does a lot of stuff. So it's one of the medication I like to use, but the problem with Seroquel is that it causes weight gain and metabolic syndrome, which is kind of a negative thing. So there has been comparison studies. So Boulder one, where they compared Seroquel, 2 doses, 600 milligrams, 300 milligrams with placebo. And you can see that Seroquel is much more effective as compared to placebo. Next slide. Lamotrigine is another medication. Lamotrigine doesn't cause weight gain, and it's also used, it is quite safe to use in actually pregnancy. So which lithium and valproic acid are not. So again, lamotrigine, some patients respond well to lamotrigine, and there has been few studies, but the data is a little bit mixed for lamotrigine. Next slide. So you can look here that the first line treatment is Seroquel. And then in second line, they have lithium and lamotrigine, divalproic acid, and a combination of mood stabilizers and antidepressants. Next slide. Now, if you use antidepressants in people who have bipolar depression, you can actually switch them to mania or hypomania, and also it can cause a rapid cycling in the mood. That is why it is so important. Like a lot of time, people who have bipolar disorder, they present with depression rather than mania or hypomania. That's why it is so important that you get the family history, whether there is a family history of bipolar disorder, because most likely then that person will be genetically vulnerable and may have mania or hypomania in future. So if you're going to use, if somebody needs antidepressants while they are, and they have a diagnosis of bipolar, and you are going to use the antidepressants, then use them in combination with a mood stabilizer. Don't use them alone. And if they start having manic or hypomanic symptoms, just stop the antidepressants then, or wean them off. Next slide. Again, as I said, there has been few studies which has shown that if you use antidepressants, they can worsen the manic or hypomanic episodes, and they can also cause the rapid cycling. Next slide. Now, we treat bipolar disorder or major depressive disorder as chronic illnesses, just like diabetes or any other chronic illness, because people who have mood disorders, these are recurrent, they have recurrent episodes. It affects their functioning. As I said before, if they are ill for like repeatedly ill or recurrence, it leads to brain damage, it leads to chronicity, more medications, functional impairment. So it is very important. Like the first phase is treating the acute symptoms. Once they are well, then you have to maintain that improvement. So let's go over the maintenance therapy then. Next slide. Atypical antipsychotics like Seroquel, aripiprazole, risperidone, all of them can be used as first-line therapy. Next slide. Again, yeah, next slide, please. Yeah, so any of the mood stabilizers I talked about, like lithium and valproic acid, atypical antipsychotics, all of them can be used as maintenance treatment. But the important thing is that a lot of time bipolar patients, they don't have insight. They don't believe that they have an illness. They don't believe that they need the treatment. And non-compliance is quite high in both depression and mania and hypomania. So in those cases, especially with bipolar illness, you have to consider atypical antipsychotics, which you can give intramuscularly. Paliperidone is used very commonly, or Abilify is used very commonly. You can give the injection once a month. For Abilify, for paliperidone, even now, every 3 months, injection is available. So then you have to consider that if compliance is a problem. Otherwise, you can use the oral medications. And again, ECT, if somebody is very, very, like if they are not responding to the medications, then ECT can be considered for treatment too. And again, we use the maintenance ECT, where they get the ECT every few weeks or every month, or depending on how the illness is. Next slide. So this shows that if you, there is a comparison between olanzapine and lithium in the relapse rates. So you can see that overall relapse for olanzapine is around 30%, and for lithium is around 38%. For depressive relapse, they are almost equal, 16 and 15%. And for manic relapse, with olanzapine, it is around 14%, and with lithium, it is around 28%. Next slide. Aripiprazole is, as I said, is available in injection form. And there has been studies for maintenance treatment of bipolar disorder. There was a long-term study. Initially, it was open label for the first 6 to 18 weeks, and then it was double blind for 26 weeks. So people who were on aripiprazole, they had fewer relapses and longer time to symptom relapse than with placebo. Next slide. This is another study looking at relapse with lamotrigine versus lithium versus placebo. And again, you can see that the medications are more effective as compared to placebo. Next slide. Lithium versus placebo in maintenance. And again, you can see the probability of remaining well was much more higher in lithium as compared to placebo. Lithium not only does that, but it is also a medication which prevents having suicidal ideations. So it is very helpful with people who have suicidal ideations. Valproic acid and lithium both, like people who have, and also atypical antipsychotics. If somebody is very aggressive, anger outburst, they are also helpful for that. Next slide. So you cannot use antidepressants for maintenance treatment. And if you really have to use them, it has to be in combination with atypical antipsychotics or other antipsychotic medications. Next slide. Okay, so what are the ones, like, what do you do when you are following somebody with bipolar illness? You need to monitor their valproic acid, lithium, even Tegretol. I don't use Tegretol that much. You have to monitor their drug levels. One is that it will let you know whether within therapeutic range, especially the lithium, because if lithium is higher than therapeutic, it can be toxic. That's not true for valproic acid, actually. So you need to, and other thing is that it tells you whether the patient is compliant with the treatment or not when you're doing the therapeutic levels. Lipids, blood sugar, metabolic parameters, they need to be done every year. I usually do, if somebody's on lithium, I usually do their creatinine and every 6 months, lithium level every 6 months, and TSH every year. For valproic acid, I'll do the liver function test every 6 months, and also the valproic acid level. Weight recording is very important because most of our medication cause weight gain. Educating them, I think, is the most important thing. A lot of mood disorder patient. That's why I used to do the radio shows, which I've stopped for the last few months now, because a lot of our people needs to be educated about mental illness and need for treatment. People think that, oh, for example, if somebody has depression, that you should be able to overcome it without treatment or medications, that it is about whether you are a weak person, although it is an illness just like any other illness. So education is very, very important. And then working with the family physician. As a specialist, you have to work with the family physicians in collaboration to treat these patients. Next slide. This is the monitoring. I already went over that. Next slide. Now, treatment of major depressive disorder. Next slide. So when you are considering what antidepressant to use in patients, you need to look at two factors. One is the patient factor, other one is the medication factor. So patient factor will be more like, how is the patient presenting? What are the symptoms that they are presenting with? For example, somebody comes who is sleeping a lot, their energy level is very low. You won't put them on a medication which causes more sedation. You will like to use a medication like bupropion, which is a more stimulant kind of medication, and it will improve their energy level. On the other hand, if somebody is coming to you who is not sleeping, then you need to consider a medication which helps them to sleep. For example, mirtazapine or Remeron. So it is very important to see what are the clinical features that they are presenting with. Comorbid conditions, if they have any medical disorders or other conditions and they are taking other medications, then you need to look at whether there are any interactions with the other medications, whether the medication you're using, they are safe. For example, if somebody comes with cardiac condition like MI or something, what medications are safe to use in these people? So you need to look at comorbid conditions. And then if they have used previously any antidepressant, what were the side effects and what were the response, and what does the patient prefer themselves? Like some patients, they have quite a bit of knowledge about medications. They will come and say to you, Dr. Rana, I want to go on Cipralex. So if they prefer Cipralex or any other medication, and there is no contraindication to it, I would rather use that because it will improve their compliance because they are choosing the medication themselves. And then medication factors, you have to look at the efficacy, how effective the medication is, whether the patient is able to tolerate them or not, whether they are having any side effects from it. Again, potential interaction with other medications if they are using. Simplicity of use is very important because with both depression, mania, and hypomania, the treatment is long-term. You have to consider a medication which they can use once a day instead of 3 times a day. It is difficult to take medications 2 to 3 times a day. So if you can find a medication, most of the medication I prescribe, I usually prescribe them once a day. And then cost and availability, whether there is coverage or not for those medications. I don't know how the system works in USA, but in Canada, there are medications which are covered by the government. Patient does not have to pay anything under G plan. And there are other medications which are not covered. So you have to look at whether the patient can afford it, whether they have any extra coverage or not with the insurance. Next slide. Some of the antidepressants which has been compared with other antidepressants and found to be more effective, but very, very minimal actually difference, are Cipralex, mirtazapine, Zoloft, venlafaxine. These are the medications which are found to be a little bit more effective than other medications. Next slide. I won't go over that. These are the clinical specifier for major depressive disorder, the way they present. And then looking at that, you will treat the patient. Next slide. Okay. Now, if you start someone on a medication and they are not responding, what will you do then? So if it is the first antidepressant you have used, and the patient is also having like side effects and not tolerating it well, or there is no response, in that case, because this is the first medication you have used, you will consider adding, instead of adding another medication, just switching them to another group. Like there are few groups of medications. For example, there are SSRIs, there are SNRIs. So you will, or medication like Wellbutrin, you will maybe go to another class of medications or switch to another medications, and especially if patient doesn't want the medication to be added. If a person has used more than 2 antidepressants, and these antidepressants were well tolerated, but they didn't have 100% response. 100% response is never present, but anyway. Then in that case, and the response is like they're partially responding to those medications, then you will consider adding another medication. In that case, you can add atypical antipsychotics, or you can use lithium, or you can use thyroxine. There are a lot of adjunctive medications. You can use mood stabilizers like lithium. You can use that. Next slide. So these are the recommendations for adjunctive medications. Atypical antipsychotics, as I said, is very effective. And then second line will be using like lithium, and modafinil is another medication. If somebody is sleeping during the daytime, very, very tired, you can add modafinil. It will kind of wake them up. So there are other choices you can use. Next slide. Then there is neurostimulation, which is recommended for major depressive disorder. There is TMS and ECT. The rest of them, I haven't used them, and some of them are experimental or investigational. I have used ECT myself a lot. The TMS is not available in our hospital. It is available in UBC, like University of British Columbia. So they usually do it. That is supposed to be the first line. And ECT actually is a very effective treatment for depression. It's around 80% response rate, and especially in elderly, like it's a safer treatment to use as compared to adding more and more medications, because elderly people are usually on a lot of medications anyway. And also a person who presents with depression and psychosis, it's a very effective treatment for that too. And there was a lot of negative kind of media coverage on ECT, although like the way it is done now, it is extremely safe. Next slide. Then you have psychotherapy. Psychotherapy could be CBT, cognitive behavioral therapy, is very effective. It is as effective as medications. But the problem with CBT is that we don't have a lot of people trained in CBT, and people who are trained in CBT, they charge quite a bit of money. So it becomes kind of difficult to refer people. But I usually ask patients to read CBT books themselves, and then I work with them a little bit on that. So there's a book by the name of Mind Over Mood, very simply written book. So what is CBT? CBT is that there's basically that a person who has negative thoughts will lead to feeling of depression. Feeling of depression will lead to negative behaviors, and that will again lead to negative thoughts. So there is a cycle there. So you have to break that cycle by changing the way you think about stuff. So that is what CBT is. Interpersonal psychotherapy is more like if somebody is having a lot of relationship issues, work issues leading to depression, then you need to look at interpersonal psychotherapy. It can be used otherwise too. I use a lot of behavioral activation myself. In the past, people used to think that if somebody has depression, they should lie in bed and not do anything. Not anymore. Now, the focus is more on that you should have a routine in your day. You should get up, go out, socialize, do stuff, have small goals for yourself, which you can achieve. So you are active, right? So behavioral activation is now like we use it with all the patients. The things I talk to patient about when I see them, one of them is behavioral activation along with the medications. Then lifestyles, diet is very important. Eating healthy, exercise is very effective for the treatment of depression. At least half an hour, 3 to 4 times a week. Yoga, smoking cessation, and omega-3 fatty acids. That's it. I'm done. If there are any questions.
Yes, thank you so much, Dr. Rana, for the very deep dive into all these mood disorders. I know I learned a lot personally. Thank you so much for taking the time. We'll now begin our brief Q&A session. So my name is Amna. I'm a University of Maryland student, and I'm on the pre-med path. So our first question is, what is the best way to differentiate between manic disorder and ADHD, because they both deal with lack of concentration?
With attention deficit disorder, when you are kind of looking at bipolar disorder and ADHD, with bipolar disorder, it is episodic, right? Like you will have an episode of mania or you will have an episode of depression. It is not consistently there. In chronic conditions, then it becomes like that, but most of the time. With ADHD, you will have a history from the childhood of like having poor concentration, being hyperactive. So that is one differentiating thing. A lot of time, like a lot of symptoms, there is actually overlap between hypomanic, like hypomania, mania, and ADHD. But I think long term, like looking at the symptoms, if somebody is presenting with poor concentration and hyperactivity as a child, very disruptive, they are very typical symptoms of ADHD actually, as compared to mania or hypomania.
That makes sense. Thank you. Our next question is, do you have experience treating patients using TMS? And could you tell us about the role of TMS in mood disorders such as treatment-resistant depression?
As I said before, I don't use TMS because it is not available, right? And I don't know too much about it because of that.
Thank you. So now a couple of questions about your field. So why did you decide to go into medicine, specifically the psychiatry specialty?
I decided to go into medicine when I was maybe 7, 8 years old. I wanted to help the humanity, right? So anyway, no, I was actually, I don't know, like I always liked it. And since like when I was a young girl, I always wanted to become a doctor. I don't know why, but I did. And as I grew older, being in Pakistan, you saw a lot of like lack of medical like health stuff available to people, poor people. So in Pakistan, we became doctors really to help other people, right? Here, the emphasis, I think, is a little bit different than what it was back home. That was the reason. And I'm still like that, that if I have a lot of patients who are on social assistance and they can't afford anything. In Canada, we have the system where people get who are not working, they get social assistance around $1,000 to $1,200 a month. You can hardly eat and live on that, right? So if a patient comes to me and says that they need some forms to be filled, and I know that they don't have money, I won't charge them. Because of the way I was raised. And when I came from Pakistan, the mindset was totally different, right? So I still have that in me, that I'm here to help people. Being a physician is my profession. I love what I do. Being a psychiatrist, actually, when I came here and I started the residency program, I wanted to be a gynecologist, actually. Every girl in Pakistan wants to be a gynecologist. So, or obstetrician. So when I came here, I went into psychiatry because as a foreign graduate, it is difficult, right? But I did get into 3 residency programs and I chose psychiatry. And for the first year, I was totally unhappy. I'm going, oh my God, what am I doing? Why am I doing psychiatry? And then I actually transferred myself to internal medicine. And I did 1 year of internal medicine. And when I was doing internal medicine, I realized that I love psychiatry. I'm a very people person. I like interacting with people. So I decided then to go into psychiatry and I just love it. This is what I want to do.
That's very inspiring that you made your childhood goals come true through hard work, perseverance, and passion. Thank you so much. Our next question is, what are some of the unique challenges and rewards of a career in psychiatric medicine compared to other specialties?
Challenges are that sometimes like one thing which I kind of feel myself is that most of these illnesses are chronic and sometimes difficult to treat, right? So you start getting kind of frustrated because of that sometimes. Like you get them better and they don't have any insight, they stop taking the medications, they get sick again, then they're back in hospital. So it's ongoing stuff, right? Never ends. So that sometimes gets frustrating. But also like seeing young people, I think that is a less important thing. More important thing is that most of the psychiatric illnesses, they have onset in very young age. Like schizophrenia, usually when you are in grade 11 or 12, people start, like kids start developing symptoms, or bipolar is very early too. So their whole life is affected, right? Their relationships, their functioning, education, their inability to function, that kind of starts getting to you, that oh my God, like this young person is getting sick, and you look at their prognosis and all that. So that kind of affects you too. Lack of, as I said, like lack of information and stigma attached with mental illness. That's another thing. And then I find it very disturbing when my patients commit suicide. In my practice, I've been working since 1995 as a psychiatrist. I have maybe 7-8 patients who committed suicide over these years that I know of. I don't know, maybe others did too. But every time one of my patients commits suicide, I find that very disturbing myself, that the person committed suicide. So, and aggression, sometimes like the patients can be aggressive. I have been threatened actually a few times too. So those are the things. Otherwise, it's fine. No problem.
That makes sense. Thank you. And for our last question, given you are incredibly involved with your community, many of our students were curious to learn how you manage your work-life balance.
I don't have any balance. No, I shouldn't say that. No, like I have a daughter who is a lawyer actually, and she has 2 kids. So while Lala was still in school, I did not work that much actually. I used to start work before like after she went to school. I picked her up myself. But once she was like she moved from here to Ottawa. She did her law degree from UBC, from University of Ottawa. So once she moved, then I had a lot of time actually. So I started doing all this community work. I had this women organization, which we do a lot of fundraising, we do educational events, a lot of stuff. And I'm also involved in lots of other things actually. So now it is becoming a little bit harder because of my grandkids. But otherwise, after my work, I have a huge group of friends who are also interested in this kind of stuff. So we all do it together, and it is not work, it is fun for us.
Yeah, that makes sense. You have to balance what you enjoy doing and what you have to do.
Sure, yeah.
All right. Those are all of our questions for today. Thank you so much, Dr. Rana, for taking the time out of your day to mentor us. Thank you.
Yeah,
I'd love everyone to please give a warm thank you to Dr. Rana in the chat box for this very informative session. Thank you.
Sure. Okay, bye.
Bye-bye.
Bye.
Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for this session is now live. And again, you'll need a 70% or higher to pass and receive certification. That link is being sent in the chat now. On to our next session dates. These dates will also be posted on our social media outlets, so be sure to follow us at TeleShadowing. Our next session will be next Saturday, December 2nd at 10 a.m. Eastern Standard Time for an OBGYN session. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming ones as well. This concludes this week's shadowing. Thank you.